Hi all, good afternoon. Thank you for joining our webinar, Redefine Indian Healthcare with Real-World Data and Real-World Evidence, organized by OHDSI India chapter, promoted by Global Value Web, with our official collaborator, JSS Academy of Higher Education and Research. I'm Lakshmi, associated with Global Value Web from multiple years, managing real world data and real world evidence related services, and also a collaborator of Odyssey Global Community from past 4 years. And I'm also one of the Odyssey India chapter lead. I would be the moderator for this webinar, and I just wanted to let everybody know Odyssey is a open source, open science community that enables the large scale analytics, and Odyssey stands for Observational Health Data Science and Informatics. The brief agenda of the webinar would be Potential of Health Data in Research and Treatment by Dr. Vikram Patil, the Odyssey Journey from Data to Reliable Evidence by Professor Nicole Pratt, Odyssey India chapter in RWD Journey by Mr. Parthiban Sulur, followed by question and answers. Now, I would like to introduce our keynote speakers. Our first keynote speaker is Dr. Vikram Patil. Dr. Vikram Patil is the Deputy Dean of JSS Aher Mysuru. He is a radiologist by profession, but heading and coordinating the digi- health data and artificial intelligence related activities at JSS Aher. His team has been involved in product validations and clinical trials for innovative technologies, along with providing clinical support for many startups and also many technology giants at JSS Aher. He is serving as an expert committee member on future skills in health tech of Government of India, and he is the Vice President of Odyssey India chapter. Welcome, Vikram Patil, Dr. Vikram Patil. Sorry,
Yeah,
and
thank you. Thank you.
yeah. Our next keynote speaker is Professor Nicole Pratt. Professor Nicole Pratt is the Deputy Director of Quality Use of Medicines and Pharmacy Research Centre at University of South Australia. She is the member of Drug Utilization Subcommittee of the Australian Department of Health PBAC. She is a co-chair of Asian Pharmacoepidemiology Network Initiative and also an active Odyssey collaborator which aims to bring out the value of health data through large-scale analytics. She also have a particular interest in new statistical methodologies to study the effectiveness and safety of medicine and in the development of tools for post-marketing surveillance of medicines. We also warmly welcome Professor Nicole Pratt for this session.
Hi, all. Thank you for having me.
Thank you. Our third speaker is Mr. Parthiban. So, Mr. Parthiban is the Vice President of Innovation and Growth in Global Value Web. Mr. Parthiban has more than 3 decades of experience with more than a decade of experience in pharma and in life science industry. He possesses a multidisciplinary skills in almost all functional areas such as R&D, delivery management, operations, consulting, business development, as well as in sales. He is the president of Odyssey India chapter. His key contribution in leadership role and working with healthcare domains are highly appreciated. Welcome, Mr. Parthiban, for this webinar.
Thank you. Thank you, everyone. Thank you, Lakshmi.
So, we will take all the questions during the Q&A session, and we request everybody to write your questions on the chat box. Without any further delay, I request Dr. Vikram to kickstart the session and share his thoughts about potential of Indian healthcare data in research and treatments. Thank you.
Yeah, thank you. Thank you, Lakshmi, for the introduction. Yeah. So, as Lakshmi introduced, I am the Deputy Dean of Research at JSS Academy of Higher Education Research. And I thank ODC India chapter for giving me this opportunity to speak on potential of health data in research and treatment. Me being a research involved person, data means a lot to us. So in today's agenda, I'll be speaking a little bit about introduction to data, some concepts of real world data, real world evidence, what data means, and what is the way forward for it in India. So with this background, I'm just going to touch on the superficial areas to understand the value of data and how it can be utilized for huge impacts. So health data is a broad term that encompasses all of the information related to person's health, including medical history, test results, and treatment plans, and can be collected from a variety of sources, including electronic health records, wearable devices, and self-reported surveys. So health data is becoming increasingly important and because of more personalized and preventive care. And by understanding one's health data, healthcare providers can make more informed decisions about their care. Just to give an example, a doctor using the electronic health records can look and tell whether certain diseases which are preventable in him can be measured and preventive actions can be taken. Similarly, the health data can be used at a large scale at a hospital level, where hospitals can look into the reasons for readmission and intervene and prevent readmissions at that level. So this I'm here quoting by an article which is published in Nature, which speaks about unlocking the potential of health data to help research and treatments. So medical records are very tricky because they are confidential, there are variations, the data archiving is different, but there has been a lot of improvement over the years. And I'm here just quoting as per this article, an ulcerative colitis patient, which is a condition of gastrointestinal disorder, whereas various recommendations for it for a particular drug. Some recommend it for 3 times, some for 2 times, but which is the best way to prevent surgery? So Peter Higgins, who is a gastroenterologist at Michigan University, instead of doing a clinical trial, he used the data which is already available in the system to understand which is the best protocol for therapy, and he's utilized it into the more meaningful research. So health data sources can be various types, right from patient examination to patient generated health data, laboratory results, medical imaging, or inpatient health monitoring. When we talk of health data, it can be either in the form of structured data, which is very well organized already, or an unstructured data, which needs to be organized. So unstructured data usually denotes the diagnosis or the laboratory results, and it's easy access, useful for machine learning, simple data mining, and it's secure for data management and easy integration. However, there are certain disadvantages which come with it, that it's usually limited in flexibility and very limited storage options come along with it. So when we talk of structured and unstructured data in the healthcare system, the structured data usually denotes the diagnosis or the lab reports, medications, procedures, all these are structured data. Whereas unstructured data are usually the clinician's notes, and there is some overlap between the structured and unstructured data. This is one more article which is published in Nature, which is a case study for suicide prevention. And here they have tried to use the structured and unstructured data and looking at interactions in EHR models to come up with solutions of how suicide can be prevented. So let's understand few more terminologies. We usually used controlled studies in our usual research environment. But now we are all talking about real world data. That means data relating to patient health status and or delivery of healthcare, and data obtained from sources such as hospitals, patient generated data, disease registries, claims, and billing activities. So in this, we can categorize them into primary data, that is usually collected through surveys, interviews, and observations to perform research, or secondary data that can be particularly generated from the hospital setting. So here we are not working in a controlled environment, but all the data that is acquired in the natural setting is used for research. So the types of real world data can be electronic health record data, case report forms. It can be from the patient generated data like health treatment history, biometric data, patient reported outcomes, the cost and utilization data, that is clinical claims data sets, or or public data sets such as CMS and EHRA, or even from the public health data, that is the government data sources or national networks and centers. So when we have collected all this real world data, we need to analyze that. Why do we need to analyze? So that we can come up with some solutions. Like we can come up with a clinical decision support system, safeguarding clinical trials, or we can look for workflow improvement, inpatient alerting, fraud prevention, population health management, or even patient profiling. So there are various ways of how data can be analyzed, right from descriptive analysis, that is understanding the historical trends, predictive analytics, that is forecasting the future, discovery analytics, where determining what to explore next, or prescriptive analytics, that is unearthing new strategies. So now we started off with a question or a hypothesis. We gathered some real world data and we did some analytics or designing. So all this put together gives us some insight or evidence. This evidence is called as real world evidence. And this is a to and fro process until we come up with meaningful answers. So when we talk of real world evidence, that is the next terminology we should all be aware about, is clinical evidence using the real world data pertaining to the usage and potential benefits of risks of a medical product. The evidence is generated in the form of a study using real world data to develop insights and healthcare decision making. It provides insights into areas including disease epidemiology, treatment effectiveness and safety, health economic value, and impact. So there are various use cases of real world evidence as well, like life science research, clinical trials and studies, most post-market surveillance, and even regulatory requirements. So we began with collecting data, we did an analytics, we even came up with evidence. So the most important, the final step is targeted action. So all this evidence, we have to implement it in a real situation, real time situation, and then come out with meaningful answers to the day-to-day problems. So what are the common applications where we can do this? This can be in the form of either researching for like cures for cancer, for conducting early disease detection, improving patient documentation, delivering telehealth services, removing human bias for better outcomes, or managing financial error and risk. These are some of the examples. It can be expanded to a huge gamut of use cases. So, but everything comes with challenges. So there are potential challenges in healthcare data as well, especially because we are looking at different kind of data sets, which is mixed. If you come to a tertiary care hospital, it's different. If you come to a corporate hospital, it's different. If it goes to a primary care, it is different. So we are collecting data which is of mixed variety. And also there is an ever-changing evidence-based medicine. And on top of that, there are regulatory frameworks which keep changing on a day-to-day basis, especially with the evolution of artificial intelligence and the huge significance being given to data. The regulatory guidelines keep changing on a day-to-day basis. So until now, we have understood certain terminologies called real-world data. Real-world data is a tool which is used in research. We have come up with real-world evidence. It is an analysis used in medicine. And we have also come up with real-world answers. That is an interpretation to all this, which can be used for decision making. So how do we go ahead in India with the real world data or real world evidence? This will be dealt with again in detail, Mr. Parthiban. But I'll just highlight about how we can look from a researcher perspective. We need to improve the availability of electronic medical records. We'll have to improve the quality of data in India. There are some lack of insurance and claims data is organized. We have to use it for potential research. Patient registries have to be well maintained. Leveraging of digital healthcare, especially with the implementation of Ayushman Bharat Digital Health Mission, we will have to look into how we can potentially utilize this situation for the digital health of India to make that data into a research data and a usable data which can be compared across the world. So government of India also has taken its own initiative in its own ways. When the peak of COVID, we all used Arogya Setu app, which was again in the form of large-scale data-driven system for pandemic control. And this is published again in an Indian Institute of Science paper, which shows how the data can be utilized for potential research and clinical application. Also, there is a lot of scope for publication for real world data and real world evidence in India. I have put up one article which says about real world evidence and Indian perspective. And also there is one journal which is dedicated for real world evidence in India. So there is a huge scope of improvement for real world data and real world evidence from the research perspective in India. Also, the government is doing its own bit with framing regulatory guidelines for everything. So WHO has its own guideline of how data should be stored and archived and shared. ICMR recently released an ethical guidelines for application of artificial intelligence in biomedical research and healthcare. And in this, it speaks a lot about how data can be used for research, anonymized large-scale data, especially for artificial intelligence or any other large-scale data analysis. And also the Ayushman Bharat Digital Mission has come up with a data management policy also, which can be implemented in every institution across India. So why we should organize all this data or come up with a standardized data is because, as you can see in this graph, the focus has been shifting from America towards the APAC countries. So the rich data, the variety of data is predominantly in the APAC countries and more so in India. So with big data analytics, we will be able to come up with certain benefits, right from the electronic health records, genomic data, behavioral data, sensor data, or public health data. We can organize all this data to improve the quality of care, make sure we reduce wait times, length of hospitalization, cost of healthcare, providing the right intervention at the right time, streamline healthcare processes, improve outcomes through smarter decisions, early detection of disease outbreaks, discovery of new social behaviors, and many more. So with this, I would like to thank the organizers for giving an opportunity to press upon my points from a research driven institute perspective of how data or organized data can be more meaningful for an implemented research across India. Thank you very much.
Thank you, Dr. Vikram. Your presentation has guided us towards the need of real-world evidence. I request audience to feel free to share your questions in the chat. Thank you. Now I request Professor Nicole to take it forward and discuss about OHDSI journey from data to reliable evidence and share the challenges and success stories that she and her team have come across.
So thank you very much for that kind introduction. Can everybody see my slides? Yes? Somebody can just give a thumbs up.
Yes.
Yes, yeah. Great. Excellent. Well, thank you all for inviting me to present today in this Indian OHDSI chapter meeting. It's a real pleasure of mine to be here today. I have been the OHDSI Australia chapter lead for 3 years now. We started our chapter in 2020, and it's a real pleasure for me to tell you our journey and where we're at and where we're going. And thank you also to Dr. Vikram for the great introduction and really talking about the value of real-world evidence for healthcare and for decision making. So I'm just going to move that out of the way. So I'm going to talk to you today about the OHDSI journey from data to reliable evidence. If I can get my slides to work. So we're going to actually go on that journey today together and know that the journey is not a destination, it's a ride. It's a long way from start to finish. So I'm going to talk a bit about the data landscape itself, what OHDSI is, in particular the OMOP Common Data Model, which is a real key function of what OHDSI does and how OHDSI does what it does. We'll talk a bit about OHDSI analytic tools and talk about some case studies of collaborative research, what kinds of research have been done within the OHDSI community in terms of generating evidence for healthcare. And lastly, I'll finish off with how you can get involved in the collaboration. So the data landscape, it's a pretty murky road, and it's really hard sometimes to see the light at the end of the tunnel. So as Vikram mentioned, the data landscape is very varied. So we've got lots of different variety of data sources, data that comes from hospital encounters, patient-generated data, just going to move that, disease registry, claims data, billings data, and lots of those data sources are in different silos. They often don't talk to each other. There's unstructured data, so we have multiple data formats across those different data sources, and of course multiple coding systems, so varieties of different medical terminology that can be used across different data sources and particularly across different countries or different jurisdictions, even within the same country itself. So you can see that the data landscape is very varied, and we need ways in which to navigate that landscape. So the real world data landscape in Australia is also a very murky place. We have federal systems and we also have state-based systems. So the states maintain the hospital data. So each of the states maintains their own data sets. We've got public hospital, private hospitals, and again, all siloed, different EMR systems, different data vendors, and so on. We also have different data sets for cancer, other registries, different healthcare data registries are also maintained by the states, and they all need to be brought together to a federal level. We have mechanisms for doing that. We have Population Health Research Network, which acts as a coordinating centre across the jurisdictional linkages, and they help to facilitate data linkages across borders. We then also have our medication data and our primary healthcare data. That is the jurisdiction of the national system. So across the Commonwealth, they maintain the formulary for medicines, and they pay for things like GP visits or general practitioner visits. So that data is again in a separate silo. And to bring all that together, we need to use the OHDSI, which is an accredited integrating authority. So you can see it's a very complex landscape for which we need to work if we want to generate evidence, real-world evidence in Australia. So we have these different data sources across states. We have different data sets across the national system, but they're all in different formats. They're all completely different to each other. So we can do an analysis in those different data sources. We can produce an analysis result. We can look at our output. But how reliable is that evidence that we've generated from each of these data sources, perhaps independently with different analysts using different code? So does the different data structure and format of the data mean the results are inconsistent? Was the same research protocol, the code and analytic methods used across those data sources? Was the protocol sufficiently detailed so that another analyst could replicate the analyses and validate the findings? And was the research methodology and analytical techniques used appropriate? Or was the adjustment for confounding factors sufficient? So you can see there's lots of different questions that we ask ourselves when we generate evidence from these different data sources using perhaps different analytic code. So is there a better way? So we could take each of those data sources that have their different data formats and transform them into a common data model. So we can synthesize those data into a common data structure. We could also take the data that's within those data structures and we can translate them to a common language or a common representation of the data elements. So now we have a common data structure And within that common data structure, we have a common language for the representation of our data elements. Now that we have our standardized data sets, we can then apply standardized analytic methods across those data sets with the one analytic file, and we can then produce standardized results. And this is exactly what OHDSI aims to do. It aims to improve health by empowering a community to collaboratively generate the evidence that promotes better healthcare and better decisions. And the vision then of OHDSI is that we live in this world that's a bit less murky, in which observational research can produce a comprehensive understanding of health and disease. So I've stolen this slide from last year's OHDSI symposium, but it really shows you how much of a global network the OHDSI community is. So there's over 3,000 collaborators that are involved in OHDSI, over 80 countries that those collaborators come from, 6 continents, but it's only one community. It's one OHDSI community across the world. In terms of the data sources, we've got over 450 different data sources. And as Vikram mentioned, they can be in a variety of different formats. So they can be EHRs, registries, or administrative claims databases. But those data sets come from 40 countries and nearly 1 billion patient records, or 12% of the world's population. So it's a big data network. So the OHDSI journey, I'm going to break it down into 3 steps. And of course, there are many other steps. But what we have is a way of formatting our data. We have standardized data. We have a process that we use to analyze those data. So we have standardized analytics. And because we have standardized data, standardized analytics, we can have standardized results. So I'm going to take you through a couple of those steps. So what is the common data model? So here is a representation of what the data model looks like. So it's a patient record, and each of the records that belongs to a patient has a specific place to go in that data model. So we have drug exposures, we have procedure occurrences, device exposures, and so on. So we have a common data structure. There's a place for every part of the data to sit and to go, and that's standardized. We have a common vocabulary that translates the data within our data source to a common vocabulary. So you can think of the CDM as a bit like a travel adapter, where we have different data sources that plug in to a common data model that produces research output. Just like a hairdryer, I can take my hairdryer to India, I can plug it in with an adapter, and it works in India just as well as it does in Australia. So as I mentioned, vocabularies are a really important part of the way that we standardize data across data sources. And there are standardized vocabularies that OHDSI uses, the SNOMED vocabulary for conditions and procedures and measurements, and the RX norm vocabulary for drugs. So a drug in Australia, perindopril in Australia is mapped to the RX norm concept ID, and perindopril in India is mapped to the same concept ID in the OHDSI vocabulary, and then we now have a common language for identifying perindopril across our 2 countries. In terms of the analytic tools, one of the advantages that we have for standardizing our data into the OMOP Common Data Model is that we can take advantage of the pre-specified analytics that are available in the methods library. So things like the cohort method or the self-controlled cohort, patient level prediction, all of these tools are available for us to use against our OMOPT data. So the Hades methods library is a suite of data analytic tools that you can use once your data are translated into the OMOP Common Data Model. And the tools that are included in the Hades suite are all of the tools that have been validated in previous research and are best practice tools for generating observational healthcare data evidence. And here's just a quick example of one of the methods. So when you use a cohort design, there's a package that you can use in the methods library where you can implement a cohort study and use a cohort design comparing two treatments using best practice large-scale propensity scores for adjustment for confounding, and you can access the code to do that online. Another advantage of having your data standardized into the OMOP Common Data Model is that you can start to use the interface applications that are available from OHDSI. So Atlas is one of those user interfaces that you can go and have a look at. So atlas.ohdsi.org, you can go on and play with the synthetic data set and work out how you can navigate the tools in OHDSI, and you can there's menus where you can do cohort definitions, you can look at profiles, cohort pathway designs, characterizations, and so on. So all of that is available for you to look at. Here's an example of implementing a prediction problem. We're looking at predicting angioedema in patients who initiate ACE inhibitors, and we're going to use a gradient boosting machine prediction model to implement this prediction problem using a whole set of confounders or predictors. Atlas will create the R package for you, and you can then implement that R package against your CDM and produce the result. Now, the really exciting thing about what OHDSI can do, it produces this analytic file. You can then send that analytic file to any other data provider that has their data in the OMOP CDM, and they can implement that package as well. So what makes OHDSI unique is that it can also scale up data analytics. So you can write your own study, you can do a single study, write your protocol, develop the code, run the results, compile the results, and you have reliable evidence. But you can scale up that analysis. You can do real-time queries, you can do large-scale data analytics. You have the underlying code, and now you can start looking at all exposures and all outcomes. And it really is a powerful mechanism for generating large-scale evidence. It's really important to note that OHDSI works behind a data firewall. So data custodians have secure data. They have privacy and confidentiality rules that they must abide by, and OHDSI works within that framework. So your data that's been OMOP'd can sit behind that firewall in an OMOP CDM. It can generate evidence, large-scale analytics or single study analytics, and produce results. And it's only the results that are then distributed to other data partners to collate results. And this is how international network studies are done. All of the analysis is done behind the firewall, and only the summary data gets transported outside of that confidentiality framework. So in terms of data sets that we have mapped to OMOP in Australia, like I said, we're fairly new to OMOPing here in Australia, but we have had some significant progress in the last sort of 2 or 3 years. And you can see here that we've got quite a few databases that have been translated across different types of data. So administrative claims data, we've got EMR data in both primary care and secondary care. We have some registries that are being OMOPed at the moment, and across different states and across different jurisdictions as well. So there's really been some really exciting progress that we've made in OMOP development here in Australia. We've also got a large project that we're working on, which is called the EMR to OMOP project. And what this project is really trying to do is create a national health data asset in a common data model. So here we're looking at translating hospital EMR data sets across Australia into the OMOP Common Data Model. And while we're doing that, we're actually trying to build the workforce here in Australia in OMOP translation. And so this is a really exciting piece of work that we're doing that's really progressing OHDSI here in Australia. So now I'm going to quickly go through and show you some evidence that we've been able to generate across OHDSI network studies. So the first use case is about how we can address evidence gaps. So here we've got first-line hypertension treatments and the randomised controlled trials that are available for the head-to-head comparison of the safety and efficacy of these treatments in first line. So you can see that there's a few gaps in the evidence that we have for our guidelines on first-line treatments for hypertension. And that's really important because actually across the world, there are very different treatment patterns in first-line hypertension treatments. So there's quite a few different first-line treatments, and it's not standard across the different sites. So what we have is gaps in knowledge, but what we need is to fill those evidence gaps. We need the head-to-head comparisons between all of our treatments. And this is where the LEGEND study came in. So LEGEND is large-scale evidence generation across a network of databases. And what this study has tried to do is really fill in the gaps that the randomised controlled trials have left in our knowledge of first-line hypertension treatments. So this study was published back in 2019, but what it did is it looked at all the different classes of hypertension treatments. It looked across a global network of databases that had been translated to the OMOP Common Data Model, so 6 administrative claims databases and 3 electronic health record databases. And it looked at data of over 5 million patients of new users of antihypertension treatments. We looked at over 55 different health outcomes, so both efficacy outcomes and safety outcomes, and we did those outcomes for each of the comparisons for the antihypertension first-line treatments. Here's just an example of the data sets that we used in that study that had all been translated to the OMOP Common Data Model. And you can see there's some from the US, there's some from Japan, some from Germany and South Korea. So there was quite a distribution of data sets across the world and large data sets as well. And so we use a standardized new user cohort design package that is available in the OHDSI framework. We got some results. This is one result looking at cardiovascular event risk between the thiazides and ACE inhibitors. And we actually found that the thiazides were superior to the ACE inhibitors, which was kind of contrary to what the guidelines were saying at the time. So we didn't just do one outcome, we did many outcomes, and we didn't just do comparison between ACE inhibitors and thiazides, we did all of the different classes. So you can see how the results can scale up to produce evidence at scale. And here's some examples of the safety outcomes, and you can see that while we had a benefit to the thiazides in terms of efficacy, there was also some safety issues. So hyperkalemia was actually significantly greater risk with thiazides compared to the ACE inhibitors. So now you can start to look at the benefit risk of treatments, not just one outcome in isolation. So I'm running out of time, but I'll just quickly go through this last example. So in 2019, this study was published, and at that time, as you know, COVID hit. In 2020, there was a question about what is the effect of COVID-19 in patients with hypertension, and there was no real evidence about the risk in these patients. So there were studies that came out and said maybe there's an increased risk of COVID or outcomes of COVID within patients who are taking hypertension treatment. And there was some fear about that, and patients were starting to switch medicines because of this potential risk. So as a community, OHDSI got together and actually addressed this risk. Do angiotensin ACE inhibitors or ARBs actually influence susceptibility to COVID-19? So we had the tools available to us. We had the data translated into the OMOP Common Data Model. We had the processes and the analytical tools that we could use to address that question. And then we produced some results. And we actually found that there was no difference in COVID-19 susceptibility in patients who are on ACE inhibitors compared to other antihypertension treatments. We published that study really quickly in June 2020, and it was eventually published in JAMA. So you can see how having this data structure and having these analytical tools available to us, we can rapidly respond to emerging safety issues as they occur. So we have the journey from data to reliable evidence. We have standardized data, we have standardized analytics, and we have standardized results. But is the evidence produced reliable? And I can show you some of the steps we've taken to actually say, yes, they're reliable. We have standardized data models. We have methodological rigor. We have validation studies to actually look at the operating characteristics of our methodologies. We can have reproducible results. We share our research protocols, our codes, and our analytical methods, and this really does help to validate findings and enhance the transparency of our research. We have transparency and openness in all of our we publish everything, all results, all study artifacts, and we do our data at scale. So we leverage our extensive data settings across diverse settings, across different data sources and across the world. That increases the generalizability and the statistical power of our findings. So how can you get involved at any step of this process? OHDSI has so many opportunities for you to get involved. You can pose an idea, you can help standardize data, you can actually design new analytical tools that help to analyze those data, and you can help interpret the results. And so we can take our real world data into real world answers. So jump on the website, ohdsi.org. You can, if you're new to OHDSI, you can go to the tab, introduce yourself, you can join work groups, and you can start on your journey in OHDSI. And if anybody in the APAC region is interested, we have the OHDSI APAC Symposium coming up in July. So you can come to Australia and you can start your OHDSI journey with us here. So thank you very much, and I'll hand back to the moderator. Thank you.
Thank you, Professor Nicole. That was very informative and insightful session. Now I request OHDSI India Chapter President, Mr. Parthiban from Global Value Web, to take the session forward.
Thank you, previous speakers who have really done a very good job in putting the real world evidence and real world data why it is really needed. And I just wanted to give some Indian context and how you can be a part of India chapter. So this is the brief agenda. I think I need to go really fast because I need to, that time is running out. So India's healthcare status, EHR in India, and what are the potential challenges, government initiatives, and maybe a couple of case studies that I've come across, and how you can be a part of OHDSI India chapter. So before I get into OHDSI, I just wanted to present about India's healthcare status. Okay, so this is the India's disease burden. What you see here is the data where in the blue things talks about non-communicable diseases in India. And this pink one relates to your infectious and communicable diseases, and the green ones are related to the injuries. This is always measured in DALY, that is disability adjusted life years. But what you can really gather is neonatal is a biggest burden for India, followed by respiratory infection and TB. And then in the non-communicable, again, your heart diseases and COPD and diabetes and maybe stroke. And then even in the communicable, you can see the diarrhea and so on as really impacting India's healthcare system. And one of the other factors is Indian healthcare spend, which is currently at 1.3% of GDP, and WHO mandates that it should be 5%, and we are moving towards that. It's going to be India has set a target of 2.5% GDP by 2025. So hopefully that would help us to get in the right path. So we see why 60% of the out-of-pocket expenditure is still borne by the patients or the patient related themselves. So that shows the healthcare spend has to happen more. And in terms of hospitals, we see that 70,000 hospitals are there in India, and predominantly in the private sector. And you see that 70% of the OP visits happens or goes to the private hospitals, and around 58% also in the private hospitals. In terms of healthcare professionals, in terms of doctors, I think we have enough number, at least meeting the WHO norms. Definitely, we have to improve the quantum of nurses that we have in India. Definitely, that has to be raised to meet the WHO norms. Uh, in terms of EHR systems in India, again, this is a very generalized thing. I cannot put one hospital to the other hospital, but in general, what we see here is predominantly paper-based system. So we are seeing some things like the details like a demographic or the prescription notes, history, clinical exam observation, and so on. And we also see a lot of hybrid paper and digital formats are coming, like your pathology reports have become digital in many ways, but still it is not uniform, consistently gone fully digital across India. So to come to that level, it will take some years. But what we are seeing here is very good progress in terms of this government data that is coming here. Like we have the digital health ID, right? ABA ID, and ABA ID, the government statistics shows around 29% of the Indian population have got ABA IDs, and out of that, around 20% of that has got 20% of Indian population have got some visit to your dispensary or your pharmacy or a clinic or anywhere. You have a record attached to your ABA ID. So you have a medical record that is there, electronic health record that is available. This is this is available in both private and public hospitals, and this may not be a longitudinal at that moment. Like right now, there might be one event or maybe 2, 3 events, but it may not be available across the whole spectrum of visits or the entities you interacted with. But that is definitely, it is growing in the right direction, and you have a number of health facilities and professionals are getting registered in this. So you have the patient registry, you have the health provider registries are coming up. So that's good. And currently, what are the challenges to conduct RW studies? Uh, Obviously, we touched upon poor data quality and interoperability. I think this remains a big challenge where we have a very varied IT infrastructure and communication infrastructure. So a lot of things in paper, a lot of data resides in paper format, and there are a lot of gaps in the data, even it is filled. So there is large data gaps we see, and between the systems, between your pharmacy medication systems, your admission system to your pathology system, the information systems, there is not a lot of things that are shared, and that there is always a challenge of interoperable across the hospital network. And of course, we touched upon insufficient finances and EHR adoption, which is really if you have more funds, more EHR systems can be implemented across different hospital networks. So that is still going to take some time. And data privacy and security issues, and we have inadequate governance policies. That is, policies are coming up, but still it is, at this moment, it is inadequate to cover the entire real world evidence studies and how it can be administered and how it can be managed. And then we also have a large pool of insurance data, and that is still not effectively used in India for these kind of studies. So one of the thing Dr. Vikram also mentioned, a lot of government initiatives are coming up. So I've listed some of the initiatives that are there, and I cannot go into detail on each of this initiative, but the main thing is the ABA ID, or the Digital Health ID. So that is a very welcome move, and that is going to really help to link the data of the journey of the patient across different hospitals and the different health episodes that person might be having across the country. And all this government is creating National Digital Health Mission, NDHM it is called. So this is actually putting the citizens or the patients in the center and covering all the stakeholders, whether it is going to be healthcare providers like hospitals, or the affiliated private entities like insurers, and the healthcare professionals, and other associations and organizations, administrators, regulators, and government. So in terms of some of the use cases, again, we have talked about some of the use cases already mentioned. So I just wanted to add on to that. We can we can bring some natural history and long-term complications of a disease. Again, this could be very useful data when we are attacking some of the communicable diseases, or in terms of the your heart-related cardiac issues. And then we don't have a good registries for rare and orphan diseases. That could be really very helpful. And we see very limited research that has been done on the health economics and outcomes. So again, these could be really very helpful studies that we can make, and especially comparing the kind of treatment or the expenses or the outcome that is happening in the private and public hospitals, and how it could be really compared and get more efficiencies out of the system. And we can go on to comparative effectiveness, brand versus generic, or biologic versus your biosimilars, and so many other studies can be done. So this is again a lot of, I was looking at the studies that are currently available in India. So we are able to see that there are 100 plus studies currently done with the Indian patients and the Indian context. So I'm quoting a couple of examples from that. So this is one cholesterol levels, uncontrollable LDL levels, and the high dose statin, and they've gone for some novel treatment strategy, and then how it is effective for this particular patient cohort group, and they see a very favorable results, and then they're published in this journal. And this could be again some your real world data or evidence that is available for the next decisions, or the next clinical decisions can be taken forward, or further research can be done to validate in a very bigger segment as well. So similarly, there was another thing, the example of new medicine that has been done for liver cirrhosis, and they have tried some UDCA as the treatment option, and again that has produced some uh, improvements into the existing methodology of treatment, and that is again that is published paper, and this can be made use by the other healthcare professionals in their own settings for the particular set of patients that they are treating. Okay, so we have come to the India chapter. Again, as mentioned by Nicole, it is an open science community, which is brings together all the stakeholders, government, industry, academia, so on. And the main purpose is to create real world evidence that would help to make a better health decisions and better care. And it is available in 100 countries, and then close to a billion records are available, and provides open source tools which you can really use for large scale network analytics. And then with this, we can do the risk prediction, characterization, safety surveillance, comparative effectiveness, data standardization, and so on. So currently, what you say, India has got three founding partners. GBW is the organization which I represent. JSS is Dr. Vikram Patil represents, and Janssen Pharma. These are the founding partners. And we also have multiple partners currently are part of our network, but we invite more Indian companies to join this thing so that we can address the problem together. So we have several universities, several service provider, even Indian Society for Clinical Research, which we are working with. So currently, what is the India chapter has got three work groups, but we would be adding more work groups as we grow further. The first work group focuses on the training and upskilling. Really, when we have to build awareness in the community. We need to educate the community how to use these tools and how to impart the knowledge. Definitely, there is a training group would be focused on that aspect, how we can bring that knowledge to the community, and also what are the data standards that need to be available for that. And then we also engaged in adding more data partners. We have a high disease burden, but not so much of a real world data that is in a usable format for large scale analytics. So we need to bring more data partners into the network. And then we also need to have the feasibility analysis work group, which is really when we are interacting with the data partners like hospitals, how the data can be, current data can be really uh, uh, transformed into a common data model that can be taken up for the your analytics, right? So there, this work group would focus on attacking those challenges and how to get the value out of the existing data that is currently there in the different data partners. So I'm coming to the end of my presentation. So we have a multiple channels available in which you can reach us, platforms. So we would like you to be join this journey, OHDSI journey, and then let us make some contribution and make difference to Indian healthcare. So with that, I close my presentation. Thank you very much.
Thank you, Mr. Parthiban, for sharing the interesting information from Indian perspective on RWE and how Odyssey India chapter can support the journey. And now the session is open for Q&A, and I request Tiasha, Marketing Manager at Global Value Web, to take it forward. I know we are running late, but we would like to take few questions and answer them. Yeah, thank you.
Thanks, Lakshmi. So we are at the last segment of today's session. So before we take a further questions, I think already there are a few questions and answer going on in our chat box. So we have put up a few questions in between the session, and let us see the poll answers now. So the first questions that we asked: what are the current challenges in handling Indian patient data for research? And majority of the people here feels that getting access to data is the major challenge. So I would request Dr. Patil to share his view on this. Dr. Patil.
Yeah, thank you, Tiasha. Yes, as rightly been mentioned by many, we usually find it difficult to get access to data and more so organized data. But if we have a structure like ODC where we start organizing healthcare data in a very anonymized manner, the main concern with health data is the health privacy related issues and the security of the patient's confidential information. But with platforms like ODC, where the data can be totally anonymized with and totally de-identified, so such platforms can be very useful for accessing data and converting them to a common model which can be used for uniform comparison of research. So we also had a very painful journey trying to organize our data. But what we have seen is when we start organizing data in an anonymized manner, in a structure by structure manner, it will be very useful for a long-term perspective.
Okay,
Over to you, Tiasha.
thank you. Yeah, thank you, Dr. Patil. So our next poll question that we asked was, what are the most important factors when generating reliable real-world evidence data using Odyssey? So the majority of people here feels that data quality and standardization is the important factor. And I would request Professor Pratt to share her perspective on this.
Yeah, thank you. So actually, I think that each of those in their own right is a very important factor when generating reliable real-world evidence. And of course, the data quality itself is one of the most important things. We need to make sure that the quality of the data that we're generating evidence from is up to standard. So I agree that data quality and standardization is one of the important factors, but I do believe that every one of those things that is there in that list is equally important. We need to have the best methods to, generate the evidence from good quality data. We need to make sure it's complete. We need to make sure that that those data are private and confidential. And importantly, we need to make sure that the evidence we generate is robust. So we need to generate, studies where there is no bias, that we've addressed any inherent bias in our results, and we're using these results to improve healthcare. So we've got to make sure that those data are robust and that evidence is robust. And the way that we can do this research, we can't do it independently. We must collaborate together. We need to have multiple heads working across the network on different study questions. And of course, everything needs to be transparent. We need to make sure that those people who are making decisions based on the evidence that we generate have confidence in that evidence. We need to make sure it's transparent, and we also need to make sure it's generalizable across the world in different settings and in different patients. So I think that every single one of those things is really important on the journey.
Okay, right. Thanks, Dr. Pratt. So there are many questions popping up, but we could finally take a few questions. So the first question that was asked was, what are the key ethical considerations when working with RWD and conducting RWE studies in India? So may I request Dr. Patil once again to answer these questions, sir?
Yeah. So, as per the current Indian guidelines, the anonymized data can be used for research. So, when we talk of even RWD data or RWE data, when it's totally anonymized, not at all relatable directly or indirectly back to the patient, it can be used for any kind of research. And the data ownership is still a debatable thing in India. There are no clear-cut guidelines. Government is trying to frame very clear guidelines. Although the patient owns the data, any data for that matter, but the data aggregators or the hospitals or any other data aggregators, when they are having data which can be totally anonymized and, as I told earlier as well, de-identified, it can be used for bulk research. I think that should answer the basic fundamentals of what's happening in India right now. But still, there is a lot of work going on from the government side, which will give clear guidelines on data ownership as a whole.
Right, very well, thank you. Okay, moving to the next question. Uh, what are the current legal and regulatory barriers or the hurdles to work with Indian RWD data? So I will call Mr. Parthiban to take up this question. Thank you.
Mr. Parthiban, you're on mute.
Sorry, I was in mute. As Dr. Vikram Patil alluded, we do not have the regulatory boundaries has been set to work with uh, to work with real world data, what are the guidelines, what should, where does the the one is the ownership part, and what is the anonymization part, and when we have the DICOM images, that images might also have the metadata about the patient, right? So there are several such issues that are there, and currently this being drafted, and pretty soon we would be having the legal and regulatory framework that would enable us to really do large scale real world evidence and studies, but that does not prevent us to doing the studies at this moment. Currently, once the new guidelines are in place, we should ensure that we adapt to those guidelines and follow that. That's all. Thank you. That would be my perspective take on it.
Right. Thank you. Quickly moving to the next question. Okay. I think we have many more questions, and we have the answers have been given in the chat in the sideline. So looking at the time, I think we have come to the very end of today's session. I would take this opportunity to extend my thanks to our eminent speakers today. I would also like to thank all our organizers for their support to make this webinar a successful event. And last but not the least, I would also want to extend my thanks to all our participants for their valuable time and for staying connected with us today. So we will be also sharing with you the recorded version of today's session.